Hi, everyone. Thanks for joining our webinar today. We're going to let a few more attendees trickle in before we get started, so stay tuned and we'll start the webinar in just a minute.
Thank you for joining us for today's webinar, Provider Readiness for Operating in Alternative Payment Environments. My name is Linda and I'm going to be moderating today's session. Before we get started, I just want to run through some housekeeping items. For the webinar today, we have quite a few participants. So for this reason, we're going to be muting all of our attendees to ensure that there's excellent sound quality. Additionally, we recommend closing any other programs that may take up a lot of bandwidth on your laptops and impact the quality of the presentation. If you have questions during the webinar, please feel free to utilize the question panel that you'll see on your control panel. We'll answer all of your questions at the end of the webinar during our Q&A portion. All attendees will be sent the companion white paper and a recording of today's session following the webinar. And we'll also be sending out a post-event survey for all attendees to complete that will help us improve for future sessions. And I'm pleased to introduce our two fabulous presenters for today's webinar. We have Donna Martin and Laura Fischer. Donna Martin is the Director for State Partnerships and Special Projects for ANCOR and has worked in the field of providing supports and services to people with developmental disabilities for over 35 years. She began as a weekend DSP in college and over time has held positions at every level of service provision. Prior to joining ANCOR, Donna has served as the Executive Director of her state's IDD Provider Association Community Provider Network of Rhode Island for 14 years. Donna has a BA from Providence College and a Master's of Education from Rhode Island College and is the mother of a 15-year-old son who has autism. And then Laura Fischer currently serves as the Associate Director over Proposal Management at MediSked, where she oversees MediSked's responses to government procurement opportunities and helps the company enhance its technology offerings for government clients. Prior to joining MediSked, Laura worked extensively in the IDD industry, starting off as a DSP and a case manager, and eventually working for the largest IDD provider agency in West Tennessee. There, Laura helped establish a Department of Care Management in response to the state's transition to managed care, and also led the agency's implementation of MediSked software as their electronic health record. Laura has also worked as a consultant to local governments on health and human services issues and done research for the Aspen Institute, a Washington, D.C. based think tank. She holds a Bachelor of Social Work and a Master of Public Administration, both from the University of Missouri. I'll now hand it over to Donna Martin to get us started. Donna, you're on mute.
My apologies. Thank you for joining us, and I'd like to take a minute to just cover quickly our agenda for the coming hour. There will be a brief overview of alternate payment methods and the differences between APM and value-based purchasing. We'll take a look at current trends in value-based purchasing and specifically in managed long-term supports and services. We'll review tasks that will help you ready your organizations for these changes. And then finally, as Linda said, we'll take questions at the end of the presentations. So to start off, I'd like to give you a little bit of background around where these initiatives have come from. The Affordable Care Act incorporated what's known as the triple aim, which intends to improve U.S. healthcare system. In October of 2007, the Institute for Healthcare Improvement launched what they titled the Triple AIM Initiative. This was designed to help healthcare organizations improve the health of a population's experience of care, including quality, access, and reliability, while lowering or at least reducing the rate of increases. Pursuing these three objectives at once enables healthcare organizations to identify and fix problems such as poor coordination of care and overuse of medical services. It also helps them to focus attention on and redirect resources to activities that are likely to have the greatest impact on health. However, these three design elements that underlie effective implementation of the Triple AIM include identification of a population as the unit of concern. This can be addressed through a registry that tracks an identified group of people over time, thereby creating a population. And for example, a population could be all of the diabetics in Massachusetts, or in our sector, people with IDD in Nebraska who are dually eligible. Those are generally the kinds of groupings that you'll hear referenced, and it's oftentimes those sort of subsets of either IDD population or elders or Medicaid beneficiaries that are targeted through state waivers for particular services. The second design element is relative to externally supplied policy constraints, such as budget limitations or the requirement that all subgroups are treated equitably. The policy constraints that shape the balance sought between the three components of the Triple AIM are not automatic or inherent, but rather they're established through a process of decision-making, politics, and social contracting with the populations involved. And the third design element is the existence of what IHI called an integrator. And this integrator is able to focus on coordination of services to help the population on all three dimensions at once. So an integrator is an entity that accepts responsibility for three components of the Triple AIM, all three components for a specified population. By definition, an integrator cannot exclude members or subgroups of the population for which it's responsible. In designing care, an effective integrator in one way or another will have to link healthcare organizations, that's including public health and social service organizations, whose missions overlap across the spectrum of care or service delivery. The important function of linking organizations across this continuum requires that the integrator be a single organization and not just a market dynamic, and that they can induce coordinated behavior among the health service suppliers to work with the population identified. The elements of care and payment models that help to achieve the Triple AIM include first, design the care delivery system with the whole person at the center. And it's recommended that states, payers, and providers involve individuals and families when designing care models. The second element is to empower people in the care delivery system itself through information, technology, transparency, all with the goal of promoting health. The third component is building care management and coordination systems. This helps to improve disease prevention and health promotion, and it is built on a cost control platform. And then the fourth element of these models include integrating behavioral health and social determinants of health with physical health, supporting a system of integration in the execution of such. So it's from this Triple AIM, from these three components of enhancing the experience of care, improving the health of populations, and reducing the cost of healthcare, that alternative payment models and one of the APM's primary vehicles being value-based purchasing or value-based contracting have emerged. So when we look to alternative payment methods and value-based purchasing, across the healthcare industry, improved outcomes and quality of life are key drivers for these healthcare initiatives. As a result, healthcare payment systems, including Medicaid, are increasingly moving away from the fee-for-service system. And they are shifting toward paying for value and outcomes, which offer the potential for improvements in efficiency, quality, flexibility, and service provision. Alternate payment models, or APMs, are defined by CMS as a payment approach that gives added incentive payments to provide high quality and cost-efficient care. APMs can also apply to a specific clinical condition, a specific episode of care, or as broadly as a population subset. Some examples include traditional managed care. We're all certainly familiar with that. Accountable care organizations, and these are groups that are formed typically of doctors, hospitals, or other healthcare providers who come together in a voluntary manner to give coordinated care and deliver coordinated care to patients. And then another type of APM, which we'll talk a little bit about as we go along, are considered or known as provider-led initiatives. Now, with regard to value-based purchasing, that is defined as any activity a state, Medicaid, or Medicare program undertakes to hold the provider or the managed care organization accountable for the cost and quality of care they provide. Other particular considerations relative to value-based purchasing is that it's required of health systems and physicians as an element of the Affordable Care Act, and it includes a % of business increase each year over a period of several years. And even in the Medicaid program, CMS has adopted goals for inclusion of value-based contracting with their MCOs. So in 2018, CMS required that any MCOs contracting with states to deliver service to Medicaid beneficiaries had to have 5% of their contracts be value-based. In 2019, that threshold went up to 10%, and in 2020, it was scheduled to increase to 20% of all managed care contracts be administered via value-based contracting. So you can see as the healthcare system has much more dramatically embraced these alternative payment methods than, say, the Medicaid system has, it is seeping into our sector. We do see it in pockets. At this time, it's not very widespread, but we'll talk a little bit in a few minutes about where we're seeing that growth. There's an issue with defining metrics. How do we determine which are the variables that we want to measure, and then use those measurements to incent provider activity. And we'll talk about that again in a few minutes. So this here is a framework. It's called the Alternative Payment Method Continuum. It was designed by the Healthcare Payment Learning and Action Network. And a couple of items that I want to bring to your attention in particular. You'll see category 1 is identified as fee for service. There's no link to quality or value there. So the more you provide, the more potentially you stand to make in revenue. That's where the majority of IDD services sit today on the continuum. But I want to draw your attention to category 2C specifically, which is pay for performance. And that's what we're really talking about when we think about value-based purchasing. That breaks out in a couple of ways, which we'll get to in just one more minute. But that's a particular element in this continuum. And then in category 3, you see it referencing the use of APMs on top of a fee-for-service rate structure. And that can be that can get really complicated, particularly from the provider perspective, because by far the fee-for-service rate systems are in many cases not quite sufficient in the IDD system. So when you start layering these additional requirements on top of what would be considered an underfunded system, it becomes challenging to actually make that work. And then in category 4, I wanted to highlight that we have a couple of pockets of this type of APM currently in use in IDD services. One example of the integrated finance and delivery system comes from a program in Pennsylvania. It's called the ACAP model, and it's an example of how the fee-for-service structure was completely overhauled for this particular pilot program serving adults with autism. And the providers ensure or provide a wraparound healthcare and long-term supports and services paradigm, and they're paid via a case rate or a bundled payment system. This here really shifts the focus on value over volume and quality over quantity. And I think that's where we will see systems continuing to evolve to. The next diagram that I have for you is essentially saying the similar thing. It's just a different representation, and I think it really helps to depict that notion of a continuum. So on the left, you see in green is the fee-for-service model. There is no financial accountability for providers, whether they're healthcare providers or IDD providers, and there is a very small chance of financial risk. But as you move through the continuum, you can see, for example, the pay for performance is sort of on the line between no accountability and moderate accountability. There's potentially some risk involved there, bundled and episodic payment models, shared savings, shared risk models, all sort of lead through to the highest level of risk being the capitation and performance-based contracting. That's where a service organization or an entity like the one we were just discussing takes on the full financial accountability, full financial management, and uses that authority to fully integrate services. So while there are definitely some upsides, there's much more risk than where we see most of the IDD services today. So when we, oops, I went too far. Okay, so when we look at value-based purchasing and long-term supports and services, we see that, as I mentioned, states are increasingly incorporating value-based purchasing on top of the fee-for-service system. While it's a good objective, the practice can really be complicated by an already challenging billing system. If lost revenue and missed opportunities result from the discrete benchmarks or thresholds that are determined for enhanced payments, it can be frustrating for providers. And generally, there are two types of value-based purchasing methods: those structured to incentivize a provider and those structured to penalize the provider. You can see in the slide here, I mentioned that funders and payers are trying to ensure they're getting quality supports by restructuring payment methods to focus on the positive outcomes. So essentially, it's looking at more of a philosophy of getting what you pay for, rather than a situation where the more you bill, the more revenue you stand to take in. So now with that, I think we are going to launch our first poll.
Thanks, Donna. So before we launch our first poll, we're just going to give a little bit of guidance on how this process works. We are going to open the poll here in GoToWebinar, and it should appear on your screen so that you can select an option. You can just read through and pick the best choice for you, and then click the radio dial for the answer you'd like to respond with. And we'll give it about 30 seconds before we close the poll and then launch the answers. So you might see a little blip in the screen, but we'll show you how everyone voted. Since voting is live, we've heard sometimes people with low bandwidth and connection issues can make it hard for them to vote. We hope that if that's the case for you, you'll keep trying in subsequent polls because it'll probably work better the next time. So our first poll is, the question is your state implementing any value-based purchasing? And the answers are yes, no, or unsure. So we'll give you about 30 seconds to cast your vote. All right. So our poll results were 37% of you said yes, 22% said no, and 41% of you were unsure. I'll pass it back over to you, Donna.
Great, thank you. So let's talk for a minute about the two primary types of value-based purchasing initiatives. The first is with regard to incentive payments. So this is a process where providers are offered enhanced payments for achieving a certain level of quality or another specific outcome. For example, an organization that I've worked with had a contract with their state, which offered an enhanced payment if the provider was able to ensure a case management visit to an individual supported within 24 hours of them being released from the hospital. This particular organization was a behavioral health care provider. And so their metric, what they were being evaluated against was their ability to ensure a case manager visited a person they served within 24 hours of that person being released from the hospital. And they needed to hit that mark 95% of the time in order to be eligible for the incentive payment. In this particular example, that provider met that goal 92% of the time during what was the predetermined contract period. The provider got zero financial enhancement for that. So you can see how this can be problematic. This type of incentive-based payment can be problematic for a provider. It's not like they came in at 50% and lost their eligibility for the enhancement. They came in 3 percentage points below. So one of the things to consider here would be to negotiate a sliding scale approach to the incentive to allow for compensation of partial attainment of the goal, or to set, maybe a floor. You have to hit at least X percent, and then, it's scaled up over beyond that. The other point that I think is important is that the incentive should be generous enough and reasonable to attain in order to motivate providers to strive for that. And the next type of value-based purchasing that's common is with regard to payment withholds. So here a provider is expected to hit a certain benchmark. The payer withholds a certain percent of their rate or a certain percent of the contract requirement. And then if that benchmark is met, the provider is eligible to get the additional funding. Now, I think this one is particularly concerning in IDD services because, as I mentioned just a few moments ago, by far and large, we generally find that states have not been able to keep pace with the cost of doing services, providing services, or the cost of doing business for IDD providers. So they are generally funded below their actual cost anyway. And so then if a state or an MCO were to come in and suggest that they're going to pay even less than that already insufficient funding level up front, that really would complicate business operations for the organization, and there wouldn't be much of an incentive there. So when we think about value-based purchasing, and we've been talking about setting those metrics, what are the metrics that are being evaluated? The issue of quality measures is really front and center. A few issues identified here on the slides is that there's not a widely agreed upon set of discrete quality measures. People's satisfaction with services and quality of life is hard to standardize, and organizations are working to identify indicators of quality and individual satisfaction. So to that end, the National Quality Forum has identified 13 life domains that are generally accepted and agreed upon. They include areas like choice and control, community inclusion, holistic health and functioning, human and legal rights, et cetera. Within those 13 domains, there are 42 subdomains, which have over 6,000 individual measures collectively. Across all current available measure sets, we have as I mentioned, over 6,000 individual measures to draw from. So this has really confounded our ability to land on a discrete set of widely accepted measures. Additionally, it's been difficult to develop these discrete measures because we're talking about things like satisfaction and community engagement and understanding and expression of one's rights. You can see that these are all kind of squishy. How's that for a technical term? It's not like measuring the number of ER visits or blood pressure or body mass index. Those are easily quantifiable measures, and something like life satisfaction is not. So with all that said, you can see how the incorporation of measures like these that are important to people with IDD do not readily align with metrics upon which we can build a value-based purchasing contract. How would we measure something like 90% of someone's satisfaction versus 5% reduction in ER visits? It's just, it's a bit more amorphous what we generally try to achieve in long-term services and supports. Now, the one thing that I think is important to keep in mind as we talk about quality and where that intersects with value-based purchasing, recently CMS issued a letter to its Medicaid directors encouraging states to move toward what they call value-based care. At the federal level, there's a movement to shift our services in that direction, yet CMS itself does not yet have a standard measure for home and community-based services. They've recently issued an RFI for feedback on their proposed set of outcomes, but there are some issues with those outcomes, or with that, that proposed measured set that they have released. They do draw from the National Quality Forum domains that I mentioned, and they do crosswalk those domains with some of the more generally accepted measure sets like the NCI and the HCBS CHAPS. But one of the concerns with this proposed set is that they are voluntary. States' participation in using these proposed measures is voluntary. The document and the proposed measures themselves are very extensive, and they have a heavy focus on systems outcomes, and not so much on individual personal outcomes, as we mentioned, like satisfaction or community engagement. I think here it's important to draw the link between quality measures and value-based purchasing. Again, you know, we've talked about how when healthcare services in the Medicare and Medicaid programs have started to incorporate value-based purchasing, it's been on those real discrete measures like incidence of diabetes and obesity and those kinds of measures. What we're talking about is a lot harder to get our arms around, and yet it is those very measures that would be needed to be used as the foundation for a value-based contract between an IDD provider in the state or the managed care entity. I think most likely, as we do see these emerge, they're likely to emerge around employment services, because it seems we have some more discrete outcomes available that are more easily quantifiable, like number of hours worked, rates of pay, does an individual receive benefits, those sorts of things. So let's see, let's move on. So when we move on to IDD services and managed long-term services and supports. Now, the value-based purchasing can happen within this paradigm or can happen as a standalone with organizations contracting directly with their state entities. But let's look at it now through the lens of managed long-term supports and services. In 2017, a Truven report cited that about 24 states had implemented managed long-term supports and services as of 2012. That number has increased since 2012. I believe it's in the range of 40 to 42 states now. However, I wasn't able to find that particular citation. If I do, I'll share it with Linda's team, and they can get that out to the attendees. But within the MLTSS universe, only 10 of those, at the time, 24 states, have included IDD services in their managed long-term plans. And primarily, MLTSS has been focused on programs serving elders and people with physical disabilities. So let's take another poll to see where we are with the attendees here.
Okay, so our next question is, has your state included people with IDD in their MLTSS program? And the answers again are yes, no, or not sure. I'll give you a few seconds to answer. Okay, so our responses were 16% of you said yes, 35% of you said no, and then 49% said not sure.
All right, thank you. So where I'm going to wrap up today is doing a real quick survey of the 10 states that currently do include IDD in their managed long-term support programs. So this has been sort of a slow but steady march to include IDD services in these initiatives. And I'm going to address them alphabetically, not chronologically, but just so you can get a better picture of what some of the different states are doing. So Arizona happens to have been the first state in with managed care for all Medicaid services. That was initiated in 1988 and has been operating in one form or another with managed long-term supports and services since then. Next is Arkansas. In 2017, the state developed a program that they're calling PASSES, and that was generated from a legislative initiative that involved providers in the development of the managed entities. So they are, this is, I mentioned at the beginning of the conversation, those programs that are considered provider-led. Arkansas's programs are among that type. It is a provider-led initiative. All of the managed care entities have, I believe, a 51% provider investment in them, and the remainder is with traditional managed care or healthcare entities, insurers. That was scheduled to be fully integrated this coming January, but with the pandemic, I'm not sure if they are on target to hit that. Next, we have Iowa. They went all in with managed care on the healthcare side, but they included community-based services, IDD, LTSS, and that happened on April of 2016. Next is Kansas. Kansas implemented managed care in 2014, again, for healthcare and long-term supports and services, and IDD services were rolled in 2015. Michigan has managed specialty supports and services, which was initiated in 2014 through a health home demonstration. And a lot of these programs, like the health homes, were an outgrowth of the Affordable Care Act. So you see most of these dates come after that point in time. North Carolina has had managed long-term supports and services without including managed healthcare since 2011, which is really, that's the only state or model that I'm familiar with that has gone that way. Typically, we see a state will establish a managed care plan to deal with certain populations' healthcare management, and then eventually roll in long-term supports and services. But North Carolina did it just the opposite way. New York has been in a state of flux for some time. They were developing a health home model, but this current year, they got a new commissioner in place, and last I heard, they were just tapping the brakes a bit on that, pending some further study. In Pennsylvania, as I mentioned earlier, they have what's called the ACAP program. It's the Adult Community Autism Program is what it stands for. That was initiated in 2008. And like I said, when we were looking at the continuum, they fall into one of those fully capitated, all-inclusive plans. Tennessee has had managed healthcare for quite some time, but around 2015, they launched their Employment Community First Choices program, which is an MLTSS for people with IDD. And did I switch that one? There we go. And then the last state, the 10th state that is currently involving IDD services in MLTSS is Wisconsin. And that was initiated around 2012 through the Family Care and Family Care Partnership programs. Wisconsin, what was unique about them is they grew their program geographically. So it started in just a few counties, grew, to more and more. And I believe last year into this year, they were just about to roll out the initiative statewide. So you can see how the passage of the Affordable Care Act, as I mentioned, has created pathways for states to think differently about how to incentivize value over volume and quality over quantity. Now CMS continues to encourage states to move toward these models, and we're likely to see it advance. So we know that this is a trend that's coming to a Medicaid office near you. So now what I'm going to do is hand over the presentation to Laura, and she's going to talk about things that you can do to ready your organization for the future.
Yep, thank you, Donna. So there are, many things that provider organizations can be thinking about, considering when it comes to making sure your organization is ready to succeed in an alternative payment model. Of course, they range in complexity, size of investment, and you'll want to pay attention to what your state specifically is doing and sort of tailor your choices from some of the options that we're going to look at here. So we've lumped these provider readiness strategies into a few different categories that you can see here. So there are actions related to strategic planning, processes, people, and partnerships, and actions related to technology, data, and measuring and monitoring data. So in regards to strategic planning, I think, it sounds simple, but it's important to, again, remember this fundamental shift that value-based payments entail, which is shifting from quantity to quality. And so, I know when I was with a provider agency, we did 1 year, 3 year, and 5 year strategic planning. And so starting to embed that shift into your big picture planning for your organization is incredibly important. And then beyond that, some other things to think about as you are sort of charting a path forward in a new environment is to look specifically at what your state is doing. If your state hasn't moved towards this yet, then, getting a sense of what's happening in other states, because, rarely does anyone completely reinvent the wheel. So you can certainly learn from what's happening in other states. And so if you're in a state where they're taking steps towards including IDD or long-term services and supports into managed care, you'll want to understand the contracts that you hold with the state, you hold with an MCO. There should be, avenues for you to negotiate or provide public feedback and comment. Donna mentioned the example of the sliding scale incentive, that's something that helps lower your risk and enhances your chance to get to that reward, to that enhanced payment. So you want to think about, as sort of atypical as it sounds for most provider agencies, you want to think about some of those legal aspects and understanding your contract and understanding what your state is doing as far as their move towards value-based payment. And then similarly, you also want to understand the contract an MCO holds with your state. You can go to the next slide, Linda. So just like you, the MCO is responsible for delivering certain contractual outcomes to the state. So it may be helpful to understand the MCO's relationship with the state And again, this is that shift in thinking, but to start thinking of yourself as a partner to the MCO to deliver the outcomes that the state is on the hook to deliver in terms of controlling costs and elevating quality. So while you'll want to understand the playing field at the state level and at the MCO level, you also will want to kind of focus on what's going on in your own backyard, your own agency. And that includes thinking about efficiencies, ways to reduce costs, because, you know, in an alternative payment model, your revenue will likely be affected, whether it's the cycle, the revenue cycle, actual amounts. And so what are some ways that you can find cost savings or otherwise ensure that you are providing the level of quality that the state is requiring for enhanced payments? So a specific example of that, what are maybe some process changes, is to look at what the clinical or acute care field is doing. Like Donna mentioned, healthcare is quite accustomed at this point to value-based payment models. And so they have some best practices that are worth looking at and potentially adapting to what you do as a provider agency. When I was with a provider agency in Tennessee, we took the approach of establishing a Department of Care Management. We didn't have any money to hire new people or create some big new infrastructure, but we looked at what these other sectors were doing and cross-trained staff on principles of care management to help be proactive about identifying risk and poor outcomes and addressing them. So still kind of talking in the vein of partnerships. We've talked about, you know, partnering well with your state, with MCOs, to kind of take that concept of partnerships even further. There are options that you may want to explore in regards to looking at the feasibility and the effectiveness of partnering with other provider agencies in your state to form a CIN, a clinically integrated network, or an ACO, an accountable care organization. So of course, I'm sure you're familiar with these terms, but in a nutshell, these types of partnerships are designed to drive down costs and manage quality of services for populations of people. Now, these are certainly, doing something like this is certainly kind of an advanced long-term option. You're not going to establish a CIN overnight. And you may even want to consider working with a consultant to study the potential feasibility or cost savings associated with an action like this. We did that when I was with a provider agency. We worked with a consultant, ultimately decided not to pursue this as a strategy. But MediSked does have clients in North Carolina that did something similar, worked with a healthcare finance consultant, and they ultimately did decide to establish a CIN and have just actually finished that process just recently. So another partnership you can consider that may not be as obviously considered a quote unquote partnership is one with a technology vendor. So at MediSked, we certainly consider ourselves a partner to provider agencies like you through providing technology platforms to help enhance the quality and outcomes of your services. So we know each provider has unique needs for their technology systems. Some of you may already have really wonderful EHRs. Some of you may still be paper-based. So of course you want to take into consideration where you are in a technology maturity level, what type of investment you can afford. But typically, what we do see that what providers value most when they make a technology investment are a couple different things. One is a system that is secure. You can look to state and federal security requirements like high trust, NIST, to gauge the sort of the level of security a vendor might provide. One that has significant storage capabilities because you have a lot of data and you have to keep a lot of data for a long period of time. Systems that can connect to other systems outside of your agency, so you can get information from partners or even from the state. And then, you know, it's important to look at a system that has comprehensive, easy to use functionality. You don't want to overburden your staff, especially your frontline staff, with a slow or cumbersome technology system. And when I talk about comprehensive functionality, I would especially mention looking at billing and revenue cycle management functionality in your software, or if you're looking to procure new software, because like Donna mentioned, moving from fee-for-service to value-based payment, the billing is probably already a pain for you, and if you move to non-fee-for-service billing, you'll find that it can get more complex, and having a software system to support that is really important to make sure you're not distressing your revenue cycle management and missing payments, getting late payments, things like that. So now I believe we have our first poll for this section, and I'll hand it over to Linda for that.
Thanks, Laura. So our next question is anyone considering a technology investment as a way to get ready for new payment models? And our answers are yes, no, or not true. We'll give it another 10 seconds for people to respond. Okay, so our responses were 47% of you said yes, 28% said no, and 26 were not sure. I'll hand it back over to you, Laura.
Great, thank you. Yeah, I know a big strategy for us in Tennessee was to enhance our EHR as we shifted to this new payment model. So certainly something to think about. And so then in addition to kind of those features we just looked at, if you're considering a technology investment, kind of a subset of that, something that's important to talk about is looking at data tracking and reporting features and functionality. Quite a few alternative payment models might include incentives for providers just to collect and report data. So you could get an incentive just for submitting a report. Of course, beyond that, as we've already discussed, you'll be getting paid based on outcomes, so just not on volume. And so you'll need some sort of way to accurately document, track, and report on outcomes and quality. So some reporting features that we think are particularly important in kind of an alternative payment model is perhaps having access to a system that provides you with dashboards with at-a-glance real-time metrics, maybe internal metrics that help you better manage your processes and efficiencies, like number of claims paid on time, maybe external metrics that are tied to your payments, such as how many individuals are achieving outcomes in their plan. Ultimately, it's important to keep in mind that in an alternative payment model, you will need the ability to report on required outcomes data, whether it's social determinants of health, something clinical, whether it's something squishy, a squishy quality of life indicator. And in addition to reporting on those things, you will want to keep track of them so that you can make mid-course corrections if you're not hitting the necessary benchmarks that your state is requiring. So I do want to say, we've talked about technology investment, software systems, that sort of thing. And while certainly a software system can enhance your ability for data tracking and reporting, that's not your only option, especially if you don't have a budget for a solution like that right now. So at my agency, we utilized Excel. I'm a total nerd. I love Excel. It's actually a super sophisticated tool. So we utilized Excel to track all kinds of outcomes, from client satisfaction to employment outcomes, while we were in the process of making a bigger technology investment in a system. So, if you feel like, well, I don't have some fancy BI tool, you can always start on Excel tracking outcomes that are important to your organization or to a payer. We're going to look in a minute at some examples of quality measures that states MediSked has worked in, have used as part of their alternative payment models. If your state has not defined them yet, or if your state isn't even talking about this, you can also always look at standard quality measure sets. It's like some of the work Donna mentioned, look at CQL's basic assurances, things like that, to either start somewhere when it comes to tracking outcomes, or to start thinking about what you might need to be set up to do in the future. So if you are wondering more specifically about what kind of data states are including in their value-based payment measurement models, we have one example from New York, and you can see their value-based measurement set here. It does have a rather clinical focus, looking at things like number of ER visits, other outcomes like shortness of breath. So this is an example of some fairly clinically focused measurement sets. And then in North Carolina, the state is still kind of finalizing their move to managed care for behavioral health, IDD, and substance abuse, but they have identified a set of categories for where they will draw their value-based payment measures from. And you can see it's a very wide range, ranging from acute care outcomes to even public health outcomes, which you could think of as social determinants of health. So those are some examples of how states are thinking about this, although like Donna said, it is difficult to kind of quantify a lot of the work that you do as far as quality of life and things like that. So we are going to pause for our final poll here.
Okay, so our final poll is, are any of you tracking any of the following quality measures: social determinants of health like housing, employment, food security, etc., risk levels, clinical data, something else, or nothing right now? And then we'll give you again about 15 more seconds to respond. Okay, so it looks like our responses were 42% for SDOH, 33% for risk levels, 50% for clinical data. That was the most voted poll, 39% for something else, and then 19% for nothing at the current moment.
Great, very interesting. Yeah, so it sounds like a lot of you know the important refrain of data and tracking, so that's great. So lastly here, kind of this last strategy we're going to look at, when it comes to readying your organization for a new payment environment, it's absolutely important to think about what is really your most valuable asset when it comes to supporting your clients, which is your staff, from your DSPs to your leadership team. And so from a big picture perspective, like we talked about earlier, there is a culture shift that likely needs to happen because, again, you're moving from this focus on quantity to quality, although all of you I know provide high quality services. So it's not only a kind of this culture shift, it's also going to change some of your day-to-day processes, because there will likely be new requirements, new regulations, things like new documentation requirements, new billing requirements related to the contracts that you hold with the MCO or with the state. And so you'll definitely want to train really thoroughly on those new requirements. It's got to be more than just sending out a memo or making an addendum to the employee handbook. This is a new way of doing business, and so you want to support your staff, especially your frontline staff, and making sure they can succeed in those areas. You may also want to consider bringing in leaders from provider agencies who have successfully done this. At my agency, over the course of about a year, we had regular sessions from a provider leader in a state in the Northeast who had done some really innovative stuff. And so it was encouraging and inspiring for us, thinking the sky is falling, with this new payment model, to see that actually this can be done, and it can be done really well. So those are some things to think about as far as preparing your staff. And then with that, we are going to wrap up, move into some Q&A. I'll talk really quickly so we can get to some questions. Just want to leave you with a couple key takeaways. The first is that it's not too early to start preparing for alternative payment landscapes. It is a trend. You will likely see it come to your state. Secondly, for better or worse, technology will play a big part in helping you navigate your way to success in a new payment environment. And then lastly, beyond technology, it's also important to invest in your people, your staff, and your processes to ensure you're finding efficiencies where you can. A last little bit of housekeeping here. We will be emailing out a copy of MediSked and ANCOR's white paper on alternative payment environments. That will come to your inbox if you have registered for this webinar. And with that, I will hand it over to Linda to facilitate Q&A.
Great. Well, first of all, thank you to Donna and Laura for the presentation. We had a few questions come in. If people have other ones, you can just put them right into the question panel and we will get them asked to Donna and Laura. So one question was, what was the name of the 13 domains? I think this was referring, yeah, this is you, Donna. Oh, you're muted again.
Sorry about that. It's the National Quality Forum that has put those domains together. You can find them at nqf.org, I believe, for the full listing. Actually, you know what I will do is I can put a link in the chat.
Perfect. Okay, and then there was just a general question about getting a copy of the slides. We're going to be sending them out, the recording along with the companion white paper that'll dive even deeper into some of the topics that Donna and Laura covered today during the webinar. We'll give people a few more minutes if they want to ask any other questions. But as people are popping off, thank you so much for, oh wait, there's another question that just came through, excuse me. Thoughts on organizations forming data governance committees proactively to review metrics? Essential participants recommended to attend these discussions. So it's a two-part question.
Okay, so I'm assuming the question is, is it a good idea for providers to come together to advise on potential, quality measurement sets that the state might want to consider? Hopefully I'm interpreting the question correctly. I think if there is opportunity for your state to receive that kind of feedback, that is an excellent tactic because, states know the healthcare sector and domain. They know what to measure there, and they do have a tendency to bring those measures over to the IDD world. Sometimes they're appropriate, sometimes they aren't. So I think if your state has mechanisms to listen to you, who are the experts on important quality measures that measure the success of what you're doing, that's an excellent tactic to take. Your state might have work groups set up. If it is a provider-led initiative, I would think they would definitely have some sort of mechanism for that. I don't know, Donna, if you would add anything there.
I think you hit it.
Okay, great. We have two more questions. So what if you were, or what is your recommendation for choosing indicators among the 6,000 options?
Well, again, I think we want to be leaning in toward those that start to collect indicators about people's community inclusion, their level of involvement, their level of connection, be it at work or around social activities, indicators that speak to a person's level of choice and control about their schedule, their lifestyle, what they do with friends, how they spend their downtime. I tend to, when I do sessions like this, I talk to people about those things that are important to you in your life are also the things that are likely important, or categories of things important in my life are probably categories that are important to people supported. And so again, I would really just sort of look toward to those rather than the system metrics. One example that I use, I think a very common measurement that we hear in IDD services, does the person have access to transportation? Well, that's fine. Access to transportation is a fine thing to measure, but what it doesn't get at is, what if the person has nothing to, nowhere to go? You might have access to transportation, but if you have nowhere to go, then what does that say about quality?
Okay, I think we have time for one more question. and that was, are there any states including vocational facility services in managed care?
I believe the states like Iowa and Kansas that have rolled in 100% of their long-term supports and services have those employment services that are also funded through a managed care model, if I'm understanding your question. It would be for sure Iowa and Kansas. And then if I think about other initiatives, I think Wisconsin through their program, I think most of the ones that have the 10 that have the managed LTSS would be inclusive of IDD employment supports.
Okay, well, thank you very much to Donna and Laura for presenting today, and thank you to everybody who came to the webinar that will be recording and the white paper coming to your inbox shortly. We had one other question in the chat. I can send the question to Donna and Laura after this webinar so that they can send a response directly to the person who asked that other question we didn't have time to get to today.
Okay, thank you.